Good morning. That's better. Can we please be seated? We're ready to start. An exciting, we've got 6 papers on innovation and technology. Can the speakers please make them their way to the front and be ready? We've got 5 minutes. We did really well in the last session. Let's keep the timings up. 5 minutes for the talk and 2 minutes for questions. Microphones are at the front here. And if we're ready with Ashish Godke, looking at the implant-free double dorsal laminoplasty. Thank you, Ashish.
Good morning, everyone. I would like to thank the spinal department at Oswestry and BritSpine for giving me this opportunity. My topic for today's presentation is implant-free double-door laminoplasty with clinical and radiological outcomes at a minimum 3-year follow-up. I have no conflicts of interest to disclose. The implant-free technique, as described by Kurokawa, involves splitting the spinous process in the midline with a burr. In our case, we preserve the muscle attachments at C2 and C7 and use the iliac crest graft, which is shaped in a trapezoidal fashion as a spacer and followed by a rigorous post-operative neck range of motion exercise regime, as you can see on the images here. From 2013 to 19, we had 44 patients who were enrolled in the study, and we had a minimum follow-up of 3 years with a maximum follow-up of up to 8 years and a mean follow-up of 66 months. The first 24 patients had no foraminotomy, and we found that 4 of those patients had C5 palsies, so the subsequent 20 patients had a foraminotomy as well. And the causes were degenerative, most of them, congenital stenosis, couple, OPLL, and a few were central cord syndrome patients who had plateaued with regards to their improvement of myelopathy. So the results and the clinical outcomes were as per the Nuric rating, and the mean pre-op scores improved from 3.9 to 2.6, which showed an improvement of 15%. The modified GOA score improved from 11.1 to 13.4 with a recovery rate of 34%. The NDI mean preoperatively was 29.2, and this improved to 21.7. With 7.7 improvement, which was significant, as the MCID for NDI is 5 in such scenarios. This table summarizes the clinical outcomes. And the functional recovery rate, as I mentioned, in our patients was from excellent to fair in most of them, and a couple had poor outcomes. The radiological outcomes were assessed with regards to the mean C2 C7 lordosis angle, which changed from 18.5 to 12 degrees in most of our patients, except 3 patients who had a loss of lordosis of more than 20 degrees. 2 of them did clinically well without any actual neck pain, but one went on to have progressive myelopathy with some actual neck pain and instability at the level above, which was the C3-4, and then went on to have a 4-level ACDF thereafter. The space available for the cord at the maximum side of compression was improved preoperatively from 8.38 to 16.5, and this was as per the post-operative MRI imaging. Again, this table summarizes these results. The other thing we looked at, because we used iliac crest spacer, was to see the union at the gutters. As you can see, this is a 6-month CT scan of one of our patients, and 90% of our patients showed union around the gutters, and also the graft united with the laminas that was spread apart. One patient, although had a loose C5 hinge and went on to develop palsy at 36 hours, there was no compression identified on the MRI scan, and this patient went on to improve to a grade 4 at 6 months. To summarize the complications, 3 patients had a loss of lordosis of 20 degrees or more, as I mentioned before. Out of the 24 patients who didn't have foraminotomies, 4 had a C5 palsy, and 2 of those patients went on to improve to grade 5, and 2 reached grade 3 to grade 4 by 1 year. The 20 patients who had a foraminotomy, which was the second lot of patients, didn't have a C5 palsy, and this was a significant finding. And this is in comparison with the latest published literature from Lee et al. In the Spine Journal in 2018. 1 patient had bone graft harvest site infection from the iliac crest. 2 had CSF leaks, which were managed intraoperatively without any post-op complications. So to conclude, modified Kurokawa laminoplasty, which is splitting the midline and as it described in our study, showed similar neurological improvement to other studies, but by preserving the muscle attachments at C2, C7 and the early post-op mobilization showed better stability, better preserved range of motion in comparison to earlier studies. The iliac graft is a good alternative as a spacer, and as we all know in UK, we are not sanctioned to use the hydroxyapatite spacers or the titanium implants. The spacers, the hydroxyapatite spacers are expensive implants and range from $500 to $1,500 US, and are used in Japan and United States. So we thought the iliac crest graft is a good alternative to this, and stability-wise, it does well. One of the limitations of our study is that it's a retrospective study with a small set of patients. We recommend a prospective study with large numbers to establish a stronger evidence. Thank you.
Thank you, Ashish. Any questions for Ashish?
I've got one while we're waiting. So you mentioned about the lordosis angle. So what's the ideal lordosis angle that you're aiming for?
So our inclusion criteria was patients who were neutral to lordotic. Patients who had any amount of kyphosis were excluded from the study. For laminoplasty, those patients went on to have a fusion procedure with implantation. And we also used the K-line to see where the pathology is, whether it's anterior or posterior to it, to decide.
Can you just tell me a little bit about the functional outcomes for patients with this? You say there's a statistical significant change in their MJOA. How did that relate to the patients' reports of how they did?
It was, I mean, functionally, as the MJOA asks you about the upper limb function and the low limb function as well, balance issues as well. So that is how we graded them as per the MJOA scores, pre-operatively, post-operatively, and there's a formula to calculate the recovery rate published in one of the papers, which we used to see if there was a significant improvement in the MJOA scores.
Good. Thank you, Ashish.
Thank you. Thank you.
We'll call on Rebecca Williams now. To talk about the use of mesenteric progenitor cells. Welcome, Rebecca.
Thank you very much for that introduction. So as some of you may know, low back pain is the leading cause of disability worldwide, and it's associated with the degeneration of the intervertebral discs. Current treatments do not actually target the regeneration of the intervertebral disc, therefore there is no clinical need. So here we see an image of a healthy disc compared to a degenerate disc, and in the middle of a disc is the nucleus pulposus, which predominantly is made up of water, proteoglycans, and collagen, which is extracellular matrix. In a disc, the harmonization of the factors biomechanics cells and extracellular matrix and their harmony is super important to to have a healthy disc. Therefore, we have a theory that putting cells back into the disc could restore disc degeneration. I did a literature review on what cell sources have been looked at in literature and for the nucleus pulposus regeneration. We've looked at differentiated cells and also stem cells. And from this, we found that induced pluripotent stem cells are a really good option as they could differentiate into any cell source. Therefore, we looked at differentiating these cells into mesenteric progenitor cells, which are found in the gastrulation period of an embryo, which hope for them be differentiated further into the notochordal cell, which is a precursor of the nucleus pulposus cell. So the notochordal cell is a really good option as it can make their own extracellular matrix and they can inhibit catabolic cytokines. Interestingly, notochordal cells are only found in human disc up to the age of 10, but interestingly, they're also found in species that don't have natural disc degeneration. So my project is part of a bigger IP spine project, and their aspiration is to put cells, specifically these mesenteric progenitor cells, I'm going to show that to MPCs, into a biomaterial, and then that will be an injectable therapy to restore a degenerative disc. So the biomaterial that we've been looking at is MP gel, which is a thermoresponsive biomaterial, and and upon injection, it goes from a liquid state to a solid state. This has been extensively looked at in literature before and is proven to be safe and efficacy. And it's also compatible with cells such as mesenchymal stem cells. So I did a pilot study for 2 weeks in vitro, and I put MEPCs into this MP gel. As you can see from the cellular structures in the histology staining, that they survived after 2 weeks. There was initial cell death, but then that was decreased in that 2-week period. And then I did a couple of immunohistochemistry staining, such as aggrecan and collagen type 2, which highlights that they produce the extracellular matrix in the biomaterial. I then looked at specific transcription factors, such as FOXA2, which is an MEPC marker, brachyury, which is an autocaudal cell marker, and SOX9, which is also an MEPC marker. And you can see that brachyury is the most expressed in these cells. I then did a different study, this time prolonging the culture study for 4 weeks, and then took a 1 week, 2 week, and 4 week time point. Again, you can see that the MEPCs survive after 4 weeks. There is a gradual decrease in cell death over time, and the aggrecan and collagen type 2 is really nicely expressed in the biomaterials. Again, I looked at brachyury and cytokeratin 8, 18, and 19, which are both notochordal markers, and this is highly expressed in the 4-week time points. In conclusion, notochordal cells really do have the potential to regenerate the IVD, as they can produce their own extracellular matrix. We found that the iPSC MEPCs do survive in our biomaterial MP gel after 4 weeks in vitro, and this is in a physiological culture condition. And then the iPSCs, MEPCs are starting to express notochordal-like phenotype in MP gel, suggesting that they are differentiating. I'd like to thank surgeons that are part of Hallam and Sheffield, and BritSpine as well.
Thank you, Rebecca. Do we have any questions? Fascinating talk. Thank you, Rebecca. So, what's next? What's next?
Yeah. So next is testing out these cells in biomaterial in an ex vivo culture system, which is part of the BritSpine project, and actually I got to visualize that and with the fellowship that I'll explain tomorrow. But yeah, putting the biomaterial cells into an organ culture model, and then that will be then put into an IVD bioreactor, so that manipulate the disc and bend it, and so the mechanical forces are actually applied to that. So it's bringing in the external forces that you would find in a spine, and then seeing how the cells fare with that mechanical force, and also the biomaterial itself.
Yeah, good. So how far are we off, do you think, that colleagues being able to use something like this clinically?
So they have been put into sheep models, this biomaterial, so two biomaterials in particular. So the next step is clinical trial in dogs, and then in humans, because the BritSpine is actually, Mariana is a veterinary surgeon, so we want disc degeneration occurs in dogs as well as humans, so it's both plug in the veterinary and also the human.
Great, look forward to it. Thank you very much.
Thank you.
Can I just say as well, if anyone's looking for an excellent employee, Becca is available soon. She's just writing up her thesis at the moment.
Okay, right, can we have Zachariah Silk, please, who's going to tell us of their experiences using a novel robotic-assisted navigation platform. Thank you, Zachariah.
Thank you. I'd just like to thank BritSpine and also my co-authors for giving me the opportunity to present this work to you today. So, as many of you will know, the aim of robotic-assisted navigation is to provide surgeons with the tool to enhance patient safety, reproducibility, and improve efficiency. And whilst there's increasing evidence to support its use and multiple platforms on the market, on the whole, it's safe to say there's limited UK experience. In Oxford, we acquired the first Globus Excelsius platform in the NHS, And the purpose of today's presentation is really to highlight our early experience. This was set up as a retrospective service evaluation of the first 172 robotic-assisted pedicle screws put in on the first 18 patients. And the primary outcome really is to describe some of the technical and radiological aspects of this and hopefully stimulate some discussion. So in terms of the demographics, really I'm using this slide to just provide some context. Oxford is a tertiary referral centre with a large paediatric practice, and the majority of these cases were not only open, but they were also paediatric deformity cases as well. So I think that's just important to bear in mind. And in terms of the results, just breaking this down, there were 269 screws used in total across that cohort of patients. 211 of those screws were planned with the robot, and 172 were actually inserted. So there was a gap there with 97 screws being put in freehand. And we divided these up into those that were planned to go in freehand, so there was an anticipated need that this should be done in a hybrid way, and some that couldn't be enacted for a number of reasons. So the primary outcome really is that the rate of planned to inserted screw in this cohort of population of patients is 81.5%. But just to break this down further, we had a look at the, I guess, the success rate across the group of surgeons that would using this platform. In a single surgeon case, the insertion success rate was 69%, and that gradually increased to 2 surgeons, 78%, and if the second surgeon had navigation experience, then that increased it to 87%. So, you know, I think the key take-home really from this is that having prior navigation experience is extremely favorable when progressing towards robotic platforms. In terms of the clinical, some of the clinical outcomes, we had one case with 2 screw misplacements. You can see here highlighted on the X-ray, and just to zoom that out. And these were in a non-threatening position, haven't been revised, but they do show some of the early challenges that you can face here with maintaining accuracy, and some of that's going to be down to soft tissue interposition, image acquisition, and also your case mix, which is heavily weighted towards deformity and open cases in this particular cohort. I think it's fair to say there are a number of limitations in the study that I'm presenting, and the jury is very much out on this, but fundamentally I would say I think we all have a job going forwards. I mean, surgeons still very much have a critical role, and I see more of a partnership rather than a sort of sudden dystopian situation where robots are going to take over the world. But our early experience is positive. We do feel on the whole that it is safe. I think with time and experience, we will also find that it will become reproducible and efficient. But fundamentally, the key take home here is that prior navigation experience is helpful and will accelerate you along your learning curve if you were looking to take this on in your practice. So thank you for your time, and I look forward to answering some questions.
Any questions?
Could you come to the microphones, please, if you've got questions?
So while we're just waiting there, can you tell me a little, it's not your study, but tell me a little about the patient experience of being operated on using a robot. How do they feel?
Yeah, so it's really interesting. I mean, obviously there was a lot of publicity around the time that the robot was put into practice, and some of the patients have been asking about it specifically. I mean, I have to say we've been very cautious in our approach. We haven't been using it in every case, and we've been very, very open and honest with informing them, especially parents and children undergoing scoliosis surgery, that this is very much in its early phase. But where we started was, you know, we would have, let's say, a multiple level deformity, and we would restrict the sort of the use of the robot to specific levels. And with time, we've kind of honed in on where we think it works best, and where we think we should stick with traditional techniques. But certainly in this cohort, where there is an interest.
Great, thank you. Thank you.
Yeah.
Thank you very much for your presentation.
Sorry, could you just move the microphone up a bit? That's it.
Hi. Sorry, Zach. Thank you very much for your presentation. I just have a couple of questions. The first one is in terms of, I know you only did a small number of adult patients, but was there a difference in terms of the accuracy of placement and the ability to execute the plan in the adult patients? And secondly, why did you choose to introduce it into long flexible curves in the pediatric population, as 4 years ago we had similar challenges at the Royal National Orthopaedic Hospital, and we, so I suppose, recognised that probably is a challenging group of patients to introduce this into, and it might be best suited to stick with lumbar degenerative patients and stiffer curves in adult patients, certainly initially.
Thank you. So I struggled a little bit to hear, but just, I mean, the first question, well, second question really relating to the use of the robot in pediatric patients. I mean, maybe I'll start with that, and that might answer your first question. So, I mean, it's fair to say that navigation in pediatric scoliosis surgery is established. I mean, Stanmore has been pioneering this for several years now, as a number of centres who've published, like Nottingham as well. So, I mean, we've very much seen robotics as an extension of that, but there are some challenges, especially in a unit that hasn't had prior navigation experience beforehand, which I think our data has demonstrated. I mean, Sean Malloy has been very good to publish his experience, and there was, you'll recall, Derek Crawley also published on some of the techniques and adaptations that you can do to try and maintain stiffness to the pediatric spine during a navigated or even a robotic case. And that's very much what we've tried to employ, and I've tried to bring some of those, I guess, some of those learnings and experience from my own fellowship to the unit. But also some of the other aspects are logistical. So the unit that I'm currently working is spread across 3 sites, and the location where the robot is placed is fundamentally in the area where the majority of the complex elective work is done. So the group has been very good at using this on the cases that are there in front of them. And you know, I think with an open case, if you have any hesitation that your screw trajectory or your entry point is off, you've got the ability to abort. Whereas with closed cases, where I think the majority of the early studies in robotics have been focused on, you haven't really got that option in the percutaneous cases.
Can we just wind up there?
Yeah.
Great debate. Thank you very much. Talk about it over coffee.
Thank you.
Thank you, Zach.
Okay, so next up we have Salman Ahmed, who's going to talk about assessing the reproducibility of PCR recovery time constant at 3T when examining spinal muscle function.
There he is.
And can I just remind the remaining speakers to be ready to come up so we don't waste time on your approach. Thank you.
Thank you. My name is Salman Al-Harthi. My supervisors are Dr. John Fulford, Dr. Jude McCain. So today I'm going to talk about MRS of the spine muscle undertaken using exercise similar to Baring's transit test to determine the rate of phosphocreatine recovery following exercise as an indication of oxidative capacity. The study was carried out to examine whether this parameter is sufficiently reliable to be used in longitudinal and interventional studies. Method: we have used 3 Tesla MRS phosphorus coil. We have examined 12 participants, 10 male, 2 female, and we have used exercise similar to Baring's transit test, which involve continuously healed horizontal back extension. However, Baring's transit test, the arms were folded across the chest, while in this study, the arms were evaluated forward as shown in this figure. As you can see here, this image is about the MRI spectra and the prism. As you can see here, this is a spectra, shows a normal state of the phosphocreatinine, and after the exercise, the phosphocreatinine is dropped down, and after the normal state or the recovery state, it returns to its normal state. And this is an example of the prism fitting. Results. The phosphocreatine time constant is highly reliable in our study with intercalation coefficient 0.88 of average measurement, with a single measurement 0.78. Also, the endurance time showed high level of reliability with intercalation coefficient 0.84 average measurement, while the single measurement was 0.73. Conclusion. PCR recovery time constant obtained from MRS exercise protocol is reliable and sensitive enough to detect potential changes in muscle function that may arise following exercise intervention training program. Thank you. We have no conflicts of interest. Any questions?
Thank you. That was a very quick presentation. Any questions from the floor? So what's the applicability to this to potential patients? So can you use this for patients? Would they be able to hold that pose?
That's a really good question. We are in a position now to develop this protocol. So the next step or the next stage should be training participant, training intervention exercise. After that, if we got a good result, we can examine the clinical participant or the patient, which most likely the low back pain participants.
Any other questions? So what were the advantages over your methodology from what's been shown previously?
Sorry?
What's the advantages over your methodology from what's been shown previously? So what's novel about what you're doing?
The golden standard in examining back pain is usually Banks-Swan's test, which is physically or any training or exercise. However, this measurement can examine the phosphocreatinine, which is helpful for the participant without any pain, without any harm, and it's really good and give us a good data to examine the level of the muscles, of the strength of the muscles.
Okay. Thank you very much. If there's no other questions, thank you.
Thanks.
Okay, so next up we have Jola Souza Silvia, who's going to talk about transformable endoscopic surgery for symptomatic lumbar disc herniation, durotomy, recurrence and reoperation. Is it superior to a tubular approach?
Hello, greetings everyone from Western Lisbon in Portugal, from the Department of Orthopedic Surgery. I bring you this complex title that even the moderator was having a bad time saying.
Sorry.
So I will not repeat it. I would like to thank the United Kingdom Spine Society's board for the acceptance of this presentation. The registration on this Congress was offered to me by Joymax, but it was requested after study conception, execution, submission and acceptance. I have nothing else to disclaim. Transforaminal endoscopy, endoscopic discectomy and tubular microdiscectomy are mini-invasive techniques of spinal root decompression, and they are gathering a lot of hype in recent literature. As you can see, they are being more published over the years. In 2023, in the first quarter of the year, we already have almost half the publications of last year. We decided to compare them in what it takes to durotomy, recurrence, need of reintervention, clinical outcomes and length of stay. And our methodology throughout this 5-year period of November 2015 to March 2020, we retrospectively evaluated 49 patients that were all over 18 years of age, with more than 12 months of follow-up, and operated by the spine unit surgeons of our hospital for both procedures that I've mentioned earlier. We established our primary outcome as durotomy, a recurrence of symptoms, or reoperation, and as our secondary outcomes, the visual analog score for back and leg, the Oswestry Disability Index, and the length of stay. Our results were this ones, mean age of 49.3 years, being 57.1% female, with a mean follow-up of 26.9 months. In what it concerns to our outcomes, the first row is endoscopic procedure, and the second row is a tubular microdiscectomy. We had 1 case of durotomy in the endoscopic, 6 cases in tubular micro, with a recurrence of 0 cases in the endoscopic series and 2 in tubular micro, and the same patients were re-interventioned. When what it takes to the VAS improvement in the back, we had 6.5 of mean points in the endoscopic, 6.7 in the tubular micro. For the leg, a little bit more, 7.8. I will remind you that is a transforaminal approach. We had a 7.8 improvement for endoscopy, 8.4 for tubular micro. And the osvostry disability index improvement was 37.3 and 39.6 respectively, with a length of stay of 1.1 days versus 3.7 days respectively. We had we established the significance of our results to 0.05, and we found them in length of stay and durotomy. To discuss, approaching the end of the presentation, middle-aged female were more prevalent in our operated population. We had less durotomy, recurrence, and reintervention in endoscopic surgery, but with different degrees of significance. The PROMS improvement seemed to be bigger with the tubular approach, but with no significance, and we had less time before discharge in endoscopic procedure. And to conclude, the endoscopic transforaminal approach was significantly better in durotomy occurrence and in the length of stay before discharge. We had no significant difference between recurrence and reintervention, VAS and ODI. We have a lot of limitations, starting from our small sample size and some design bias. This is our bibliography, and I would like to thank you very much.
Thank you. The floor's open for questions. If you've got any questions, please come forward to the microphones. Can I start off just with a simple question? So I'm a fundamental scientist, so excuse me if this is a simple question, but what's a tubular approach?
The tubular approach is a progressive dilation method that opens a working channel where you are able to visualize you have the same operative field as in an open approach, but with a much smaller incision that, when taken out, all the retracted muscles take their place, their earlier place, and it was one of the areas of expertise in our hospital, and yet we had 6 dural tears in the pooled patients. But now we are starting with the endoscopy, and we are having some promising results. But this is the technique.
Thank you. And a question at the front?
Yeah, thank you. I'm just confused as to why you're keeping your microdiscectomies in for 4 days. So are these a different group of patients? You're saying 1 day for endoscopy and 4 days average for microdisc?
Yeah, as you thank you very much for your question. As you could see, being an area of expertise in our orthopedic department, we still had 6 dural tears. So and some of the patients had a headache after surgery, and we were we work in a public hospital, so we hadn't much pressure on discharging the patients, so we decided to be more focused on their care of the wound, to see if there were no cerebrospinal fluid leaks, and if the patient headaches were improving. So that I think it was the reason we had such a bigger length of stay.
Okay, thank you.
Okay, one last question. Session.
What was the learning curve for the tubular versus endoscopy? Was there a difference? Because 6 out of 49 with the dural tear in the tubular group. So was that matched, or is there anything?
I'm sorry. I thank you for a question, but I couldn't understand the first sentence. Oh, the learning curve. Yes, it's most of the literature that has been published till this day showed that most of the centers that did randomized controlled trials and the meta-analysis that reviewed them and so on, they showed that for endoscopic procedures, the clinical outcomes were better with endoscopic surgery, and we didn't achieve as much satisfaction for patients. Well, we didn't evaluate satisfaction, but we didn't obtain we didn't attain such good results in PROMs because of this learning curve, because we did our first endoscopic procedure in our department in 2018, so we have a 5-year span, and it was the first 2 years of development of this technique. And it's written that one of the disadvantages of it is it has a high learning curve, so it may be a bias here, because we were experienced in tubular approaches, but we were not in endoscopic approaches. That's why we didn't attain such a good release that provided better clinical outcomes.
Okay, thank you very much.
Thank you very much.
Okay, so it's a pleasure to, sorry, you'll have to continue the conversation at the coffee.
Just mentioning about the learning curve, there's a brilliant paper which has recently been published about the learning curve.
Maybe catch up at coffee. Thank you.
Thank you very much.
Okay, and the last speaker of this session is Shehzwan Halim, who's going to talk about, does chemical shift MRI improve visualization of pars interarticular defects?
Thank you very much for the opportunity. These are disclosures, and spondylitis is the term given to defects of the pars and is leading cause of back pain in adults and athletes, nearly about 50%. And athletes in cricket, rugby, and tennis that require repetitive lumbar loading and extension and rotation are particularly vulnerable. The treatment is generally non-operative, a period of rest, activity restriction for 3 months, but the important bit is to accurately diagnose an early detection of a pars defect to allow the bone to heal in time and to prevent spondylolisthesis. And in radiography, CTs, MRIs, and bone scans have been used, but with the CTs, there is the possibility of radiation. This is a CT scan on the left side which shows the pars defect very clearly, and you can see something going on with the MRI side, but not as clear. Recently, the use of T1 wipe has improved and has shown to be as accurate as CT in terms of gold standard diagnosis for a pars defect. But these take a lot of time to acquire the imaging, about 2.5 minutes, and which may not be very practical. I want to discuss chemical shift imaging that utilizes differences in the position frequencies of fat and water molecules, where the initial image is acquired with the molecules going along with each other in the same direction, creating the in phase, which is a bright signal. And then in the second image, there is the out phase where the fat goes opposite to the water molecules, creating a dark image with a black boundary effect. In the line diagram, you can see the molecules are going the same direction initially in the in phase, and in the out phase, the fat molecules go the opposite way. This is an example of a normal MRI on the left, but an in phase on the right side, which shows the red side is the normal pars, and on the right side, you can see a defect in the in phase. But in the out phase, you can see a darker image and black outlines, which show the pars more clearly. To the best of our knowledge, this diagnosis of pars defects using chemical shift imaging has not been assessed, and we wanted to compare the accuracy of an MRI scan conventionally with a chemical shift imaging. We used a 6-week follow-up period for lower back pain of all the patients who've been referred to our department, and they had all the imaging required, except exclusions such as tumors, traumas, infections, and post-operative. We used a Siemens 3T and a 1.5T scanner and obtained local approval. The initial review was by 2 fellowship-trained consultant radiologists, but we also had a group of a spinal surgeon and 2 senior musculoskeletal radiologists who performed the gold standard report in case of difference of opinion. And we defined a complete pars defect as a disruption to the tubercular bone extending to the cortices. Each reviewer then individually examined the in-phase and the out-phase, and on a Likert 5-point scale, where 1 being normal and 5 being a definite pars defect, graded all imaging. We repeated the imaging later after a week, and we used correlation studies. So we had a total of 70 patients in a 6-week period which were referred, of which there were no pars defects in 59 and 11. So we assessed a total of 140 pars on either side. In a pars defect correlation where we asked the question of whether there is no pars defect, we found that there was a very high correlation with the no pars defect. And in a yes pars defect, again, there was high but not as high for the pars. This showed that both the phases are reliable in diagnosing or ruling out a pars defect. But on deep analysis, the scores for the pars defect for the in phase were a bit lower than the out phase results, which showed that the out phase may result in improved reporting with increased confidence. We also assessed the in and out phase correlation separately, and we found that there was again a very high correlation, which indicates that both readers were able to confidently diagnose correctly on both phases. There's no current consensus on how best to diagnose a pars defect. Most centers use a combination of T1 wipe along with the CT, but the ideal imaging modality would be the one which provides good information on the chronicity, on bone edema, on soft tissues, bone anatomy without having any radiation. So the T1 wipe definitely has the potential to replace the CT scans, but obviously it's very time consuming. Chemical shift imaging therefore is quicker, it's complementary, and you don't need to have another scanner for this, and analyzes pars defects quickly. The out phase is superior in terms of defining the pars defect, whereas the in phase is better at deleting the intact pars. The limitation of the study is low number of pars defects, but we propose to do a study on confirming the CT versus the chemical shift imaging, because CT is currently the gold standard. And we propose that this should be part of a routine MRI of a lumbar spine in every department. Thank you.
Thank you very much. I think we've got someone coming up to the microphone. Yeah, go for it.
Thank you very much. Rajat Verma from Manchester. I just want to, I know neither you or I are radiologists, but does the accuracy of this modality depend on the size of the magnet? So is it better to have a 1.5 or is it better to have a 3T?
I'm sorry, I did take out a slide for the sake of timing. So the normal T1 takes about 98 milliseconds to capture the images, whereas the chemical shift is done in about 13 seconds overall. The 1.5 is double the time of the 3 Tesla. So yes, there is an increased number of time, but I think that's still much, much less as compared to a normal T1 or a T2 or a stirred image.
No, I didn't really, not much interest in the timing. Is the quality different?
No, there's no difference in quality. Yeah.
Thank you.
For questions? Yep.
Rav Jayasuri from Sheffield. Just a very quick question. Were they all symptomatic pars defects, or did you have some incidentals that you collected?
All the patients were referred over a 6-week period with back pain for more than 6 weeks. So yes, and some of them had pars defects, some didn't.
The problem with using MR to look for pars defects is often the fact that you don't get the sagittal cuts in the right place. And sometimes you can see the pars well on one side, but you can't on the other. And you can see it well at L3, but you can't see it well at L4. So how do you get round that in this sequence? Do you change the protocol for how thin the slices are?
I think the normal slices, the smaller ones, are a bit more diagnostic, as opposed to larger ones where you can jump over the area of concern. Yeah. But I think using a thinner slice probably is better.
Okay, so if there's no further questions, thank you very much.
Thank you.
So that closes this session. Can we just thank all the speakers again for their excellent timekeeping and very interesting talks.